Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk.
Thank you so much, Brian. Don't know if I'm an expert in many things, but I will try my best with bone health and HIV, which I thought would be a good complement to the series that has been ongoing with respect to HIV and issues that we think about a little bit more with an aging population and non-communicable diseases. With that, I'll get started. I have no disclosures or conflicts. And this is the standard disclaimer surrounding any trade or brand names for products. And we'll start with just a brief case. You have a 50-year-old man. He's living with very well-controlled HIV. He's on dolutegravir and TDF-FTC, brand name Truvada. And he basically comes to your clinic because he tripped over his cat, as all cats are, mischievous, and he sustains a ground level fall. So he doesn't really strike his head or anything, but he does fall onto his outstretched hand. And, the next day he comes to your office for an urgent type visit because he's like, look, I have a lot of pain and swelling. There's diffuse tenderness to palpation on exam. And so you order an x-ray, which shows this. Not great. I am not a radiologist nor an orthopod, but not great. And so, beyond the initial management of the wrist fracture, this talk is sort of thinking about what other workup and management should occur for basically this guy who fell from, again, ground level, standing, which is a low trauma, low velocity fall, but did sustain a fracture. And we're going to talk a little bit about bone density related issues in people living with HIV as a result. So basically, it's always, I think, helpful to go over definitions of what actually is low bone mineral density, what is osteoporosis, what is osteopenia. And so for this patient who has, again, sustained a fracture as a result of a from height standing / ground level fall, that would classify as a fragility fracture because we don't really expect people, if they are falling from not so high, to have a fracture of any kind, really. Most commonly, these are hip fractures or wrist fractures, as in this patient. And that is one way that you can diagnose someone with osteoporosis, very low bone mineral density. But the other ways to diagnose osteoporosis would be by doing DEXA scanning and having a T-score or a Z-score less than a certain amount. And so just a refresher, a T-score is basically when you look at the bone density for a person and compare that to a sex and ethnicity matched cohort, but for a young and healthy cohort. So specifically from ages 25 to 35, you're comparing your patient to this 25 to 35-year-old sex and ethnicity matched version of them, essentially. And if the number is basically an expression of standard deviations from the mean, so a T-score would be of let's say minus 2.5 or more negative than that would be they are less than 2.5 standard deviations from mean, meaning that they have quite low bone density as compared to, again, a 25 to 35-year-old who is sex and ethnicity matched to them. A Z-score, conversely, is actually age matched as well. So again, cohort is sex and ethnicity matched, but people also in their similar age range. The cutoffs are a little bit less clear for that, but less than 2 is basically abnormal. So that's the definition of osteoporosis. And then osteopenia is sort of the step before osteoporosis, meaning really just that the T-score is between -1 and -2.49 at the hip or spine. And then another thing to consider is osteomalacia, which is when the bone matrix is not very well mineralized. And the most common cause of this is severe vitamin D deficiency. So just in terms of epidemiologic risks, people who are living with HIV have a much higher fracture risk as compared to people who are not living with HIV. And there are a few really good meta-analyses that are out there. I've put the citations down below if you are very interested in digging into this. But I will tell you that the ranges are a little different, but I think everyone sort of agrees that the odds ratios of a fracture are anywhere from 1.5 to just over 2 times higher for people who are living with HIV. This is not actually fully explained by low bone mineral density, but it is also helpful to know that low bone mineral density occurs in anywhere from 40 to 90% of people living with HIV. So this is a common issue. And so why does this happen? Great question. So I would put this into sort of 3 buckets. related specifically to HIV, related to medications for HIV and comorbidities for HIV, people living with HIV. And so the first bucket is HIV related. I will say there is not like a fantastic amount of information out there about this. It is like a little hand wavy, but the long story short is that we think that there is, much like other processes that we see with aging and HIV, even if people are very, very well controlled with respect to virologic control, they may have some ongoing kind of chronic inflammation and immune activation, which may increase bone turnover. And that might relate to why people have lower bone mineral density compared to others who are not living with HIV in their age cohort. There's also some question of whether HIV proteins themselves mediate increases in osteoblast activity, meaning increasing bone breakdown, and may promote osteoblast apoptosis, meaning that the things that are actually making the bones are dying. So that is potentially why, like specific to HIV virus itself, that may be one mechanism. The big thing also that we think about a little bit more is actually antiretroviral therapy related low bone mineral density. And so it's helpful to know that, unfortunately, like any ART initiation is actually associated with a 2 to 6% decrease in bone mineral density, which is pretty equivalent actually to what happens for people with menopause. So it's a pretty substantial amount of bone mineral density loss. Why this happens, not fully clear, but it does tend to stabilize after 1 to 2 years of being on ART, which is helpful to know because obviously we, like, for many different reasons, want to get people onto their antiretroviral therapy. The exception to this would be TDF. So that specifically will lead to ongoing bone loss, like as opposed to like kind of most other ART, there's an additional 1 to 2% loss like every year, which is not ideal. And this is actually exacerbated by people who are on ritonavir boosted PI regimens with TDF. Reasons being, we think the TDF may act on the proximal tubule and cause increased like renal phosphate wasting. So maybe that, like, again, mediates some bone turnover effects. Separately, ritonavir boosted PIs may act on vitamin D metabolism. So there may be some kind of synergistic effect there. In summary, obviously, we want people to be on their antiretroviral therapy. There's a small amount of bone loss, but equivalent to postmenopause changes. With that, if TDF is used, though, there is ongoing loss. And then the third bucket would be like people who are living with HIV may have other comorbidities that are common and can cause secondary osteopenia, osteoporosis. The most common thing would be like vitamin D deficiency, which, like, in the Pacific Northwest, I feel like that's probably a lot of different people anyway. Hypogonadism, specifically low testosterone for folks as well. That's, like, I think something that many of us see frequently. Excess alcohol use over 3 drinks per day. In the endo guidelines, they would say over 2 drinks per day, but kind of more alcohol use is associated with like lower bone mineral density. Smoking is a big one. Nutritional status, like low BMI, that's also one thing that's associated with secondary osteoporosis. And then things like hyperthyroid and hyperparathyroidism as well. So now we know, I think we already knew, but now we definitely for sure know that there's a higher epidemiologic risk for people who are living with HIV and having lower bone mineral density. So who do we screen? When do we screen? How do we screen? And the answer in the US is really pretty much get a DEXA. I've included this flow sheet here from a paper that was published 10 years ago now, but I think can still be helpful. And I think the flow sheet has like a lot going on in this, so I'm not going to like really dive into this in the time that we have today. But I think the major things to know are that like at age 50, all men with HIV should be screened with a DEXA. And for all women or people assigned female at birth, they should, like after menopause, they should be screened as well with a DEXA. There is like kind of a gray area for younger adults, like let's say between ages 40 and 50, where you might consider earlier screening if they have some risk factors. And this is where the FRAX score can actually be really helpful. So the FRAX, as you may know, and we'll go over in the next slide, does not specifically account for HIV or the medications associated with it used for HIV. We don't really account for that in terms of low bone mineral density risks, but it can still be, so you shouldn't use it to decide like, for this person over 50, like, should I screen them or not? But in between, again, that like sort of gray area, 40 to 50, you can kind of risk stratify about like, hey, do I want to screen this person a little earlier? And these are the risk factors that are included in FRAX. Specifically, they do account for other things like glucocorticoid use or RA, and like hypogonadism and stuff like that in the risk calculator, but it does not account for HIV. So this is just for you to look at if you would like. And something that I thought was kind of nice from the last endocrine guidelines too, were that like not only thinking about risk factors in terms of like specifically low bone density, but also thinking about factors that just like generally increase the risk of falling and subsequently fracture. So if people have like gait or balance issues as a result of like neurologic disorders, they may have like impaired vision or hearing, if they are just generally like super frail, if there are environmental factors surrounding like what their living situation is like, and like, are they going to trip and fall over something? Walking those large dogs is apparently a thing, or being tripped up by small dogs. Those are all things that you can kind of consider when you're thinking about screening. And then, like, let's say you get the DEXA scan and you get like someone with a T-score of like less than 2.5, or even if it just shows like osteopenia, there's stuff that we can do about that, which is great. I will say that there's not a ton of difference between what happens for people who are living with HIV versus not living with HIV in terms of management of either osteoporosis or osteopenia. We're going to really emphasize lifestyle changes, like trying to do strength training to build muscle mass, to increase bone density. We're going to ask people to like stop smoking for so many different reasons, but one of these is bone health related. We're going to try to ask folks to decrease their excess alcohol intake as well. One important thing is to rule out osteomalacia, which, like I mentioned earlier, is decreased bone mineralization in the setting of vitamin D deficiency, most commonly in this country. And that's important because if you start like a bisphosphonate for what you think is osteoporosis and it's actually osteomalacia, there can be actually increased fracture risk. And so it can be hard. Let's say you just got like a screening DEXA because like this person was like 50 now and like you got it and it showed that there was low bone mineral density. There actually is, you can't tell or differentiate on a DEXA scan, like what is osteomalacia versus osteoporosis or osteopenia. You are really going off of symptoms and labs. So osteoporosis really should not be very symptomatic. The lab should be pretty normal looking, except for perhaps the vitamin D. Osteomalacia, people may have pain, and they also may have increased alk phos in terms of like bone turnover, decreased calcium, decreased phosphate, increased PTH, etc. You could also check an X-ray for like pathognomonic signs like looser zones, which I am not really super sure how to interpret, but you could do it. And then again, in terms of meds, otherwise, so this is where I think the information, there has been some more update in the last few years. For osteopenia, you should try to like increase vitamin D intake and supplement with calcium vitamin D until the deficiency is resolved. There is, I would say, some controversy about the role for calcium supplementation specifically. There's been a lot about whether or not dietary calcium is better than calcium supplementation. Does calcium supplementation increase coronary calcium? Maybe, we don't know. Obviously, for us in HIV world, the conversation about calcium and potential absorption and spacing out from ART is one that is always on our minds. The current guidance is to try to increase dietary calcium as much as is possible. And if that's not really working, to then supplement with supplemental calcium, I guess. But the targets are pretty high. It's supposed to be like 1,500 milligrams a day, which is like not what most people are intaking. So just know that there is some controversy there surrounding optimal calcium repletion. And then once you've kind of fixed any vitamin D deficiency for, we think, a year, the most current HIV like primary care guidelines would suggest rechecking a DEXA in 1 year. There is like probably some nuance in that there is a difference in someone who has like osteopenia with a T-score of like minus 1.1 or 1.2 versus someone with a T-score of minus like 2.4, which is getting pretty close to that 2.5 cut off for osteoporosis. But generally, you're just going to recheck at some point in the near future to make sure that the osteopenia is not progressing. And if you really do have osteoporosis, you would probably be doing this for osteopenia as well, but you should really consider changing your ART regimen off of the TDF if you can, because like I mentioned again, you're going to be expecting 1 to 2% additional bone loss per year with the TDF. You should start pharmacologic therapy as well for osteoporosis, just like for anyone else who is not living with HIV. There's the most robust data for bisphosphonates in people who are living with HIV. the data basically just says like, yes, it works, which kind of makes sense because why wouldn't it? There's not really a lot of extra specific data for other agents like denosumab or calcitonin or anabolic agents, but we presume that they work also. And then also remembering to replete testosterone if people have hypogonadism, which should be checked as well. These are the references if you'd like, but in terms of takeaway points, again, just know that fracture risk is significantly increased 1.5 to 2 times in people who are living with HIV. Really, we're pretty aggressive about screening with DEXAs at the very latest at age 50 in men and postmenopause for women. You can consider, again, like checking FRAX scores or calculating that for earlier than that. And then treatment of osteoporosis is the same either way, like for people who are living with HIV or not living with HIV.
Thank you for watching this edition of the Mountain West AETC Project Echo Didactic Series. If you like this talk, please click the red subscribe button and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.